Mitchell Sarkies is going to present our most recent sprint audit. So Mitch is a senior lecturer and NHMRC Emerging Leadership Fellow at the University of Sydney School of Health Sciences. He has a clinical background in physiotherapy and leads multiple programs of research, harnessing implementation science and complexity science, not sure I know what that is, Mitch, to enhance evidence-informed models of hip fracture care. Thank you.
Thank you very much, Sarah, and it's really nice to be back in Melbourne actually, because I did my PhD here and moved up to Sydney, and apologies to my Sydney colleagues, but you just can't get a good cup of coffee in Sydney. And before I start, I just want to make an acknowledgement of the ANZ Hip Fracture Registry in terms of giving me the opportunity to lead this audit. And particularly Associate Professor Rebecca Mitchell for linking me in with the team, and definitely Jack for doing the nutrition audit and sort of paving the way and making it a much smoother process for me to undertake, because all those processes had already been put in place. So we're going to talk about the initial results of that audit. And I don't have a acknowledgements slide, but I just want to say I don't have any direct conflicts of interest to note, apart from the funding of my fellowship, which is for the hip fracture work, and also just an acknowledgement of the broader team there who I have listed. I don't have my cue thing. There we go. Okay, so I'm just breaking the talk up into 4 sections, and starting off with a little bit of a background. So I've heard the term preaching to the converted a little bit at this audience, and I probably don't need to preach too much about the importance of mobility and rehab after hip fracture. But just to give a little bit of background on the guideline and the clinical care standard, which suggests that mobilisation should start the day after surgery, people should have access to a physio assessment, and patients should be offered the opportunity to mobilise once per day while in hospital. And then we obviously have the more recent Cochrane review update, which Kathy, who I'm pretty sure is still in the room, was pivotal in this piece of work, and showing that the benefits of interventions to improve mobility after hip fracture. So off the back of that evidence base and those guidelines, we have our 2 sort of main questions in the registry, which are about the provision of opportunity to mobilise on the first day. And we can see that things are pretty good across the board, across Australia and New Zealand, hovering around that 90% mark. So I think there's probably only a little bit of improvement at the margins in terms of providing that opportunity for mobilisation. But then the next question, which was only added quite recently to the registry, we can see we only have 2 years of data for this question, which is about, did people actually walk on that first day? And those numbers are sitting sort of just below about 50%. So about half of people are not mobilising first day after surgery, despite most of them being offered the opportunity to. And this has also come off the back of the UK sprint audit, which Jack gave a lovely introduction to, so I won't hash this out too much, but basically what they found over there, and this was back in 2017, I believe, was around 68% of people got out of bed after surgery. It's just worth noting that that's not quite the same definition of mobility that we use in the registry. That's why that number's probably a bit higher. But about 7% of those only achieved it for fewer than half of their patients. Patients achieved an average of about 2 hours of physio in the first week after surgery. So I don't believe that's 2 hours per day. I believe that's 2 hours over the course of the week. And just over 40% missed a day's therapy at some point in that first week because of unavailability of a physio. And I think that was attributed to staffing over the weekend. There's also been some subsequent research that's come out of this audit showing that reductions in time to discharge from hospital were associated with an additional day of physio, greater than that 2 hours of physio in the first post-operative week, and an additional 30 minutes of physio provided across that first week. So we wanted to run a similar audit here in Australia and New Zealand, and really try and delve a bit deeper into those two questions about being offered the opportunity to mobilise, whether people were actually mobilised, and then delve a little bit more into the processes of acute rehabilitation in those first few days or first week after surgery. And again, Jack's given a nice intro to how the sprint audits work, so I won't hash this out too much, but basically it's a prospective data collection of a few extra questions, and we ran this in June 2022. It's an opt-in process, so the facilities that wanted to take part voluntarily took part in that, and the patient eligibility for the registry is provided there. We added 6 patient-level questions and 5 facility-level questions, and as Jack suggested, we could only get the facility-level data for Queensland. We couldn't get patient-level data for that. I'll just say now, so we got 36 facilities that took part. 29 of those were in Australia and 7 were in New Zealand. We had 437 patients, about 339 in Australia and 98 in New Zealand. So quite similar actually to the numbers in both the other sprint audits. So here's the interesting part. So I'm going to go through the patient level questions first, and then talk about the facility level questions afterwards. So the first question we asked was around what was the day that those who mobilised actually achieved mobilisation. So we've got that information from the regular data collections on day 1, but what I was quite interested to figure out was, okay, for those who didn't walk on the first day, when did they actually walk? And we can see that there's a fair chunk that then achieve that mobilisation on day 2, day 3, and you can see that day 4 is sort of a little bit higher, and that's because that's day 4 plus. So that's anyone who walked beyond 4 days is grouped into that category. So that's why that one's a little bit higher. And there was only really a relatively small number of patients who didn't mobilise at all during their hospital stay, so 20%. And we have a little bit of unknown data there too. The definition of mobilisation in the registry is standing and actually taking a step or walking or step transferring out of the bed. So if you just stand still next to the bed, that doesn't count as mobilisation. What we were also interested in was which professions are actually attempting that day 1 mobilisation, and probably not huge surprise to people that it seems to be primarily being driven by physio, but there is a certain number of patients who are being mobilised by physio with the assistance of nursing staff or occupational therapists or allied health assistants. And what's quite interesting is those who are being mobilised without physio input at all, there's sort of like around 10% of those in New Zealand that are doing that, whereas it seems to be a lot less common in Australia for people to be mobilising without the input of physio. And just noticing that that none category the numbers don't quite line up with those who didn't mobilise, because this is referring to the professions attempting those who mobilised. In terms of activity achieved, I was also quite interested to have a look at, for those who didn't mobilise on day 1, did they undertake any other activity that sort of sat just below that threshold of what we use as a definition for mobilisation, which is still potentially beneficial activity. So we can see that there's a fair chunk of people who who like stand or step, perhaps next to the bed, who don't necessarily meet that threshold for mobilisation. And a few who are mechanically hoisted out of bed and sat out of bed. And again, sort of low numbers of those. About a quarter of people actually don't do any activity on that first day. So whilst we have, about half of people who don't mobilise, it's probably only about 25% who don't manage to get out of bed at all. The reasons for not mobilising after day one, unfortunately, we didn't get great information on this. So we can see that there's a lot of reasons listed there, but you can look at that unknown category is quite high. So unfortunately, I think it's probably the nature of the way the data is collected, often from the notes. Perhaps the reason why people didn't get up day one wasn't documented, and that was unable to be captured very well. But we can see that, for those who the reason were listed, we can see some of the main culprits that we would expect there, which might be nice targets for quality improvement activities. We also looked at the number of physio sessions in that first 7 days after surgery, and I've just got the averages up there. So we're sitting just below 1 session per day for that first 7 days. So this is potentially an opportunity for improvement. The recommendations that we should be trying to see people at least once per day. I'm suspecting that, this is possibly a weekend effect, possibly, people on Sunday not getting seen, if I had to guess. But we've seen from certain studies, like the study from Laura Kimmel here at the Alfred, where they were actually getting people up 3 times a day, which reduced hospital length of stay by around 10 days. So, there's obviously a big gap between seeing people less than once a day and 3 times a day. So I think there's room for improvement there. So on to the facility level questions. We wanted to look at some of the processes and pathways in place at hospitals around acute rehab. And so one of those questions were around, we wanted to figure out eligibility criteria for subacute rehab. And probably the best way to ask this question was more around, are there any ineligibility criteria? So are there any criteria where that makes a patient not eligible for subacute rehab? And the inability to mobilise and a patient not having any rehab goals were the sort of most common ineligibility criteria for rehab, and those two probably don't shock too many people in the room. But a couple of interesting ones are previously living in a residential aged care facility. For around 20% of the facilities, this was, as in the hospitals, this was a reason to not be referred to subacute rehab. And we can see some of the other reasons there as well around, there's even a few hospitals had a sort of an age criteria above a certain threshold, those with impaired cognition, and there was also, if there was poor bed availability and a long wait list, that could also play into eligibility for rehab. The acute to subacute transfer process itself, we're a bit curious to see if there were hospitals with more sort of routine automatic transfers to subacute, but as you can see there, predominantly it's that standard referral, assessment for rehab, and then put on a wait list for a bed. So that one probably doesn't shock too many people in the room either. Another question, this really came out of our colleagues in the APA around the Australian Physio Association around, were there any practices or processes in place to get people up day 0 after hip fracture, which I think that would be incredibly hard to get people walking day 0. But there were a few facilities that had processes in place for either nursing staff to lead or physios to lead, attempting to get people out of bed on day 0. Majority of facilities didn't do this. They just tried to get people up on day one, but there's that sort of like 10% or 11%, 6% that have those processes in place. Another question we had was around additional allied health assistant roles. So this was, what were the activities that allied health assistants were contributing to getting people up with a hip fracture? And predominantly it was around providing additional opportunities for mobilisation and extra opportunities for exercise. That might be, in the chair or in the bed type exercises. Provision of extra education, and there were a few facilities that didn't have access to allied health assistants. And another thing we looked at were around criteria for referral to weekend physiotherapy. There were a few hospitals actually that had blanket referrals, so all hip fracture patients were routinely referred to physiotherapy over the weekend, and quite a large number had criteria specific to that day one after surgery. So if they were day one on a Saturday or a Sunday, they would meet criteria to be seen by a physio. And there were a few other more nuanced criteria in that other category, but it was sort of too hard to summarise all of those. But this is quite promising in terms of coverage for weekend therapy, I think. So to wrap up and hopefully eat up a bit more time so we can go into questions in the panel. In conclusion, those who do mobilise during their acute hospital stay, most achieve mobilisation on day one, but there are around 40% of people who then subsequently manage to mobilise after that first day. Physios sort of most often are doing that attempt to mobilise day one, but that there is a proportion of people who are mobilising without physiotherapy assistance. About a quarter of patients don't achieve any sort of activity out of bed on day one, and there's 35 to 47% achieve that activity below the mobilisation threshold. On average, patients receive just under one physio session per day, first 7 days. Interestingly, the patients previously living in residential aged care were ineligible for rehab in around 20% of facilities, and more than 10% or just over 10% of facilities have processes in place to actually get people up day zero. And most facilities provide weekend physio over day for their day one post-surgery patients. So those are the real things that jumped out at me. And I'm really quite excited to talk with people in the audience around, okay, what next for these areas of practice and where are there further opportunities for quality improvement. This is me, if you want to get in touch. Thank you.